this computer done. And then that should start. Yep. So we're officially recording, FYI. So let's start off with simple things. So let's start off with vital signs. Tell me what a normal heart rate is supposed to be, roughly.
Mm. 60 to 100.
60 to 100. Good. My next is going to be pressure, and it looks like someone's already on the way to go ahead and jump on that. So some say 120/80, some say 118/75. The standard that I understood within our book is somewhere in between those ranges. So your job is to understand between these two situations, what would an abnormal heart rate look like, right? So too low or too high. So we would need to know what too low looks like and what too high looks like. And it's just obviously whatever's outside of that range. Blood pressure is going to be no different. So let's talk about blood pressure. The top number, what does that represent?
Systolic,
Systolic,
Oh, good. And the bottom?
diastolic,
diastolic,
Very good. And we would know that anything that is above that range or below that range could potentiate some issues, correct? So let's talk about specifically if our pressure was too low, how would we act?
Intoxicated.
I'll take that as gospel because you're going to be dizzy, right? You don't have, for whatever reason, you don't have the oxygen supporting your brain thought to keep your body
Where's Taylor going off?
and other things of that nature. All right, so we're slow, we're low. What does our skin look like?
pale,
pale,
Pale. Very good. What's another word for pale or blue skin?
Cyanosis.
Cyanosis or cyanotic. Perfect. And when you're dealing with cyanosis or you are cyanotic, what does capillary refill look like?
slow,
Slow. What is considered normal capillary refill?
Like 3 seconds.
less than 3 seconds.
Less than 3 seconds. Good. So anything in excess of that would be considered sluggish, right? So what would be some conditions that would cause a sluggish capillary refill? Come on, you can do this. We've talked about this. Think about it. This is a situation with oxygenation, right? We got enough oxygen in the blood and hypoxia. I like that. All right, let's look into a little bit more. What are some serious conditions related to hypoxia that are pretty common conditions? So when we hear the disease process, we think, yep, that's hypoxic right there. I know you guys got this. I'm asking an out of the box question and now you're like, who's going to do it? COPD. Yes. Perfect. I love that. COPD, asthma exacerbations. These are great, right? So perfect examples. Good. And then what if it is too high? Come on, I got 20 people on the horn and nobody's talking, really?
Heart attack.
They're
Heart-
going to become sweaty.
Sweaty. Okay. 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 I like all of those. Why a heart attack though? Tell me the why behind that.
When I think of high blood pressure, I'm thinking of my dad. I'm thinking of blood clots. I'm thinking of stroke.
Stroke.
All the things that he went through when he had high blood pressure.
Okay, okay. And we'll get into that. That's going to be definitely something that we talked about a little bit further. You can't hear me or can't hear everyone else. I'm confused. You have to enable your microphone, which is going to prevent you from being able to hear. Sorry, I'm just reading the chat box. So let me know if you still have problems. I'm watching the chat box as it pops up. So blood pressure that is too high, again, we're going to be sweaty, we're going to be anxious, we're going to be all of these things, right? Okay, well, let me explain to you a concept called energy, frequency, and vibrational pattern. So think about it. When we are exhausted, all right, we have just worked all day. I just, chatterbox for 3 hours. It was annoying. And you were just gassed out. Do you even have time to think?
No.
No. So
Oh.
is that low energy, low vibration? Cool. Now, conversely, let's do the opposite to the extreme. So too high. When you have too much, I don't know, caffeine, too much caffeine, what do? You're thinking about this all at once, right? Kind of sounds like something's going berserko, right? Which is your blood. It's just go, it's just like your heart rate. Does that make sense? So when we think about these things, if we forget to, we need to not memorize, right? We need to understand the concept, because memorization is going to get me jacked up when I'm worried. But if I understand a concept of energy, frequency, and vibration, if I am low energy, if I am low vibration, if I am low frequency, I am Eeyore, I'm ready to just be passed out. Thanks for noticing me. That's the deal. Whereas it's the opposite to the extreme if you're doing something that is over the limit, right? I am freaking out. I'm pinging all over the place. I'm pacing. You can't pace when you're so exhausted. Does that make sense? So when you think of these symptoms and you go, I don't know which way it is, they're all really close but confusing. Remember the simple concept of energy, frequency, and vibration. If you got that, you can figure it out. Cool. All right, so let's talk about, let's switch. Let's go to, we talked about blood pressure, we talked about heart rate. What's normal temp?
98.
E-
I heard a lot of answers.
97 to 99.
68.6.
Okay. So we have a normal range, and what would be anything outside of that range? So like would 100 and, I don't know, 100.8 be considered out of range?
Anything over 102, right?
Well, I mean, you could theoretically have 103 degree and 102 degree temp is definitely not within range. Okay. So when we look at things that a lot of times, a lot of people say a threshold for medication is 100.1, right? So 100.1 would be the threshold for I've got to give them some Tylenol because that's too high. So it's actually a little bit lower than that. Normal temperature varies. Sometimes it's 96.8 to 98.6. Mine usually carries a little bit low as well. So let's see, respirations. Tell me about respirations. What are considered normal range?
20.
12 to
12
20.
to 20.
12 to 20.
Cool. So an increase in respirations, what could that be an indicator of?
Fever.
Anxiety,
Okay. Anxiety.
Drugs.
fever, pain.
Mhm. Good. So all of the things basically. Specific to pain. How can we understand that a person is in pain if they're unable to speak?
They can
Facial
go
expressions.
Facial expressions, such as
body language, like clenched jaw, worried eyes.
grimacing. Yeah, I see that too. Clenching your jaw, grimacing, guarding, right? Like if someone's hurting and they're like, oh, I'm fine, but they're like grabbing their shoulder and you try to hand them something to the left hand and they don't grab it. Yeah, that would be considered guarding. So good. How would their walking be if they have abdominal pain? What would that look like?
On a hunched over, maybe.
Hunched over. Again, this is the whole type of guarding mechanism. Perfect. How do you understand how do you understand how you would assess somebody for pain? What do we need to do? What type of questions do we need to ask?
The pain scale question first.
Pain scale
0 to
question.
10.
All right. Related to pain scale, if I have someone who says that they are in a 10 out of 10 pain and they're calm, what do I assume?
Got
They're
there.
That they're in 10 out of 10 pain.
Thank you. That they are in a 10 out of 10 pain. Perfect. Good job, Austin. So let's back up the train here. So if I say I'm 10 out of 10 and I'm texting or I'm playing Tetris, right? My favorite game to play. So if I'm doing those things and I'm like, yes, I'm in a 10 out of 10. How do you know that I'm in a 10 out of 10?
Because you told me.
You told us.
Thank you. But I'm calm and I'm playing Tetris.
Everybody handles
That
pain.
doesn't
differently.
matter.
Your
We
mind
cannot
on
judge
it.
by your pain.
Good.
It's what
I
you
don't-
say, not what we say. If you tell me you're in pain regardless.
I love that. All right. Perfect. So the main thing that we need to think about here is, remember, there are certain conditions where pain is unbearable. There are also certain conditions where pain isn't really a thing. So a prime example is a person who has an autoimmune deficiency, right? Or autoimmune
Like
disorder.
sick-
Sickle cell, yeah, perfect. Sickle cell patients are in incredible amounts of pain. They're very, very young a lot of times. So I see them when they're in their, early 20s. These guys are on like pain pumps, taking an ungodly amount of really, really tough stuff. And they're sitting there talking about, hey, how'd you do your rice today? Your rice ain't right because you didn't do it my way, right? And they're cutting up and laughing. This is considered a defense mechanism or a distraction. Tell me about chronic versus acute pain. This is a chronic condition. So how is that going to differ from acute pain?
Acute is new and chronic is more long-term.
Very good. Can you give me like a time frame?
More than 3 months.
Chronic 6 months or more.
6 months.
I like 6 months. I like 3 months. 6 months was the traditional way. 3 months is what I believe is the book way. They say 12 weeks. Generally speaking, they're going to tell you if it's a chronic condition. It's usually going to be below the 6 months or above the 6 marks or 6 months. I haven't seen a change in that in any platform. If you do see it, let me know so that I can review it and look at it so that I can be like, all right, cool. Because that might be something new. But from what I've read thus far, I haven't seen anything to tell us otherwise. What do they need to tell us specifically about the pain?
Location.
Location,
Characteristics of pain.
characteristics. What are you guys rattling off right now? What is it called?
Concept. Old
On-
cards.
on-
All right, so let's talk about old carts. So,
Concept.
onset, good. So tell me when it started. What's next?
Duration.
Ooh,
Sorry,
Location.
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 Oh, there you go. Location. Where is it? Is it in your head? Is it in your knee? Where's it at? All right. D.
Duration.
Duration.
How long does it last when you have the pain? Remember, all pain isn't 100% of the time. Okay. C.
Characteristics.
Characteristics. Does it stab? Is it scorching? Does it feel like lightning in your body? There are certain conditions where it physically feels like you get lightning strikes in your foot and it feels like you're being struck with a small voltage of light. Like, I don't know how else to explain it. It's a thing. All right. So that pain is very different than a pain that is gnawing, right? Or agonizing. So those type of descriptors. A.
Salivating factor.
Aggravating
And
factors. What makes it worse? What irritates it?
makes
When
it
you
better.
walk, does it hurt worse? Right?
Maybe,
What about R?
maybe if the patient
Radiation.
already seek
Radiation.
treatment for that pain.
Hang on, Victor, my friend. I didn't hear you. What was that?
I was wondering maybe if the patient already seek another solutions or treatment for this pain, or is there a recurring?
Yes, absolutely. We need to take that into consideration. Like, is this something that is there a correlation that we can find? I had a patient, that's a great point, actually. I had a patient who every Sunday would pass out and they couldn't figure out why this pass out problem was happening. And I said, hey, what are you? And she said, I'm Pentecostal and I'm a devout Pentecostal. And I said, oh, I know that very well because I've studied that very well. So when you pray and you celebrate and you worship, do you throw your hands up in the air? And she goes, of course I do. And I said, show me what that looks like. And she goes, hallelujah. And when she did, she turned her neck this way. And I said, oh, well, that's bizarre. How long do you do that? And she said, the entire song. All right. What was she doing when she does this? Now, recall, she also, we found out later, had a brewery right here because I knew to listen for it because I got that little bit of information. So what was happening? She was occluding her carotid and it was already had some sticky stuff in there. So when she did that and she was worshiping and she was dancing around, right? She was moving and feeling it. She caused herself to have a blood flow and supply shortage and she would pass out. Ha, how about that Sherlock Holmes moment? So this is why these things are so important. Does that make sense? It's a good point. So let's see, AR. What would R be? We said aggravating factors.
Radiation.
Relieving factors. So what makes it better or what makes it worse and then what makes it better? So how about sit down and then that way you don't get so passy outy. How about don't jump up out of the seat? Give yourself a second before, lead up to the worship, whatever you need to do. Cool. Things of that nature. And then T.
Time.
Yes, sure.
How long are we talking about? Does it last this long? Does it last that long? Like, again, we're trying to get pieces to the puzzle so we can put it together. All right. And then after that, there's an S at the very end. And what is the final S? I'm trying to, you might have a plushie in the background. Yeah, we're going to get rid of that. Whatever. Sorry. I'm trying to look like I'm halfway put together, but I'm not today because kids. All right. We're on S. What is S?
Severity.
Why is it so significant? Why is severity so significant with old carts? Severity is significant because I need to know if I have 6 patients on a unit and I've got this patient over here with a 4, this patient over here with a 9, this patient over here with a 10, who am I taking care of first?
10.
And
So this is a triaging situation, right? So like I need to get an idea of how severe that is to them because my severe is not your severe, right? So like I had babies and I choose not to take any medication or have any type of epidural. Why? That's just my personal preference, right? There's whatever. So if your personal preference is the same, are you going to have a higher pain tolerance because you've been used to that pain before? So it's a memory. Yeah, of course. Versus somebody who obviously gets an epidural and then has another kid and they have it on, I don't know, in the middle of a very safe, beautiful island, right? Where there's no ambulance to help out. And you have it naturally, that's going to be an increase in pain. So if you're used to dealing with pain, that pain is desensitized, much like a chronic condition versus an acute condition. Can you have an acute on chronic condition?
yes.
Give me an acute on a chronic condition. And that's a bonus question because that's a hard one.
So you have back pain and then you suddenly, like that's your chronic, and then you fall and break your ankle, and that's an acute.
So proud of you. By the way, there's nothing acute about pain. Boom. Lame. All right, cool. So let's talk about IV fluids. Give me some IV fluids. Start naming them off to me.
Normal
Point
saline, lactated ringers.
Dextrose.
Good, good.
Lactator ring.
Very good. So let me explain this. It's a very simple concept. So the simple concept goes, if my number is lower than 0.9, because it is normal saline, AKA what's in my body, right? If it's lower than 0.9, it is hypo or below tonic. Does that make sense? If it is over 0.9, then it is hypertonic. Okay, so 0.45, is that number bigger than 0.9 or smaller than 0.9?
Smaller.
Bigger.
It is smaller, or nope, 0.09 versus 0.45. It is a bigger number. I'm sorry, my brain isn't working. So then is it going to be hypertonic or is it going to be
Hypertonic.
Hyper.
No, it's smaller. I'm like, wait, why does that feel bad? Why does that feel bad? Stop. Let me correct myself because I totally just made a mistake. 0.9, and write it down because I had to write it down in my brain because I've got like 15 things going on because of the thing we talked about earlier that we don't need to re-mention. So 0.9 versus 0.4, 0.9 is a larger number, therefore 0.45 is hypotonic because it is a smaller number. So we go down. Okay. D5, hypertonic, hypotonic, isotonic. Which one?
Isotonic.
So isotonic would be anything that has the properties of the number 0.9. It would be equal to your body's equivalent. If I'm putting D5 in you, that wouldn't be normal saline, but that's a good point. If it is D5, you're
Mhm.
point in that. So it's a whole number. So it's hypertonic because it's a bigger number. Does that make sense?
Copy that.
Cool. All right. Just wanted to throw that out there.
Thank you.
No problem. So I heard lactated ringers earlier. That's curious. I like that. Lactated ringers is a stable solution that we have that we give to a lot of people for surgical settings to keep their fluid volume and maintain a good blood pressure while not putting in a whole bunch of the normal saline, which is a sodium chloride. Chloride or sodium is salt. We don't want to throw a bunch of salt in a person unnecessarily, right? Because it leads to swelling and fluid retention and other issues. And sometimes it can get into something called hypernatremia, which is too high of a sodium content in your body. What happens with hypernatremia? What are some symptoms that you would have? Think about it. If you are so dehydrated because you got so much salt in
Sodium.
your body and not enough water in your body,
Swelling. Edema.
cool. I like that. What else?
Edema.
Yeah, edema. Yeah, for sure. So when we have a patient that has this type of problem, what happens is you have a problem with, I want you to think about making Kool-Aid or making sweet tea, right? You have water and you have sugar, right? So change the sugar to salt in concept. You don't want too sugary of a drink because then you get sick, right? So what happens is when you have too much salt in your body, you start to have very bizarre symptoms because what does salt do to a slug? Anyone ever seen
That
some
shrink up.
Evaporates it.
shrinks up, right? Cool.
They're trying
Now, let's think about this like we think about the skin. If it's cold and I'm dehydrated, what happens to my skin?
Shrivels up.
It shrivels up because the water goes away. And then what happens to my skin? It does what? If I knock it up against something,
There's
break.
Hairs.
it breaks, it tears. Okay, cool. Same situation with your cells in your body. So what happens is we have an issue where neurologically our brain cells shrink and some of them pop open. And what happens when you pop a cell and there's blood in it? We pop that open and then our other cells crack open and then we end up getting a hemorrhage. Does that make sense?
Yes.
Brain gets dry essentially, and we get silly in the head and we start having some major issues. Does that make sense? Because those cells are bursting and cracking open. Easy enough? Yeah. Cool. These are really hard concepts. You guys are killing it. I'm really proud of you. All right. So, so we talked about fluid volume deficit and what that looked like. We talked about anxiety and what that looked like. Tell me about depression. What does depression look like?
Loss of the interest in natural and normal things.
Yes, loss of interest in normal things. I physically don't want to get up to go to the bathroom because the thought of me getting up to go to the bathroom, I've had patients tell me this, the thought of getting up and going to the bathroom, they would haggle themselves and say, I can literally just wait another 20 minutes. This is just the idea of nothing gives me any satisfaction. Everything is very daunting. And what is the biggest concern related to a patient that has these type of symptoms? When I hear something to that extent, what is the first thing that I'm thinking about?
Complications like suicide.
Aside.
Beautiful. The next question I'm going to have is, oh, okay, well, are you having thoughts of harming yourself? The follow-up question, if I get a yes, is do you have a plan? Why is do you have a plan matter in the world?
because if they've really thought about it, they've already planned it out.
So a funny thing about ideation of any type, be it homicidal, which means I want to hurt somebody, or personally, is a lot of times statistical data has shown us that the plan is the last ditch effort to feel as if they have anything of any value within themselves to keep themselves going. So when you have somebody that has an actual plan versus I just feel like I want to die, and please let me explain that situation as well because I can clarify it. When you say someone has a plan, at that point, if you reject them, the likelihood that they are going to act on that plan, be it successful or unsuccessful, they're going to some extent take it to the next step, is significant. Significant. Like it's so significant that I almost don't want to tell you. It's that significant. Take it very seriously. That's not to say that if they don't have a plan, don't pay attention to it. That's very serious. But in that headspace, they are truly looking for someone to care. And that is the breaking point a lot of times, too many times, unfortunately. When people say that they want to die, but they don't have a plan, Please don't think that that is them trying to get attention. That is a common miscommunication. That is not what that means necessarily. Now, every opinion is varying, but here's an opinion that I get often related to that topic. That relatable comment is, I am so stuck in everything that is going on around me that I just want to go in a corner and die. And that does not mean necessarily that they want to act on that, which is why they don't necessarily have a plan. I say this to you because, again, everyone's going to think differently. But I would say if it's over 60%, I'm going to tell you about it. And this is well over 60% of those patients that I've spoken to. Because remember, I have a personal relationship with everybody, every single one of you. You all know. That is the correlative comment that I get. So I feel like that's important to share to you guys. All right, let's digress and get back over. I'm actually just checking boxes to make sure I've got all the things covered that was in your reading material. Okay, tell me about an SBAR. What is an SBAR?
Situation, background.
Assessment and recommendation.
Cool. So very quickly, I'm gonna run through this because I don't even know what time it is. Oh, it's 9:34. Okay, cool. So SBAR, situation. Let me explain this from a doctor's perspective, not being funny, haha. I just need to say that because a lot of nurses get really irritated giving a full-on SBAR. I've been doing SBAR since I was a nurse, since I got started in her year. And it was important to do that. I was working at level 1 trauma at the time in Dayton. Very nice place. Still love it. And I was there for a while. And what I noticed, guys, if you can mute, if you hear yourself talking, what I noticed in the middle of working there, and I honestly just lost my whole entire point because I heard someone just jump in. Can you help me out real quick? Sorry. Like I told you, that thing is on my mind that we were talking
You
about.
were talking about when you got
SBAR.
your first SBAR.
Yeah, thanks. I appreciate it. So when you're working in a brand new unit and you're a doc, a lot of times as a provider, you have to do 7 days on straight. And that means you sleep in the hospital down below, right? There's like barracks for them or bunkers or whatever. Bunkers, sorry. Hostel, sorry. So when you have hostel downstairs, you can sleep there, you can chill out there. There's like a lounge, da 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 da. So you do that and you're stuck there for 7 days basically, or whatever your contract says. Everyone's a little bit different. So the last 2 days is usually your on-call days, which means you're on standby to just kind of pick anything up. So you can get calls from the whole entire house and you are essentially home, but you're answering phone calls. Now, a lot of these guys are crashing because they've had to get up every hour on the hour, depending on what's happening. So when you call them at whatever rando hour you call them at, a lot of times when they answer, they are literally in a dead crash of sleep. If you've never worked 12 to 16 hour days or done a full on-call shift that's a 7-day stretch, you are so incredibly gassed out that the thought of doing simple math gives you a migraine. Okay. So when you call them, SBAR really gets it down to the point because the way that you present that is going to change their reaction. All right. And for good reason. So keep that in mind when you're talking to them and they sound really gruffy. They don't have enough time to explain that to you because they're so exhausted they can't. All right. And remember, they're human too. They do silly stuff too. They pick their nose too. They put an entire pizza on their chest and they bite. And sometimes they bite air because they forget it needs turned while they're playing video games because they're finally off. I'm not saying that from personal experience. That would be embarrassing. But I'm just saying, we are people. Treat us like people. We're not machines. I promise. Not all the time. So situation, tell me why you're calling me at 3 a.m. and it better be good. It better be life, limb, or eyesight. Okay. Don't call me about a lab value that can wait until the morning. That's silly. Don't call me about a potassium that's, 3.1 instead of 3.2. We could send a text for that. What I need to hear is, hi, I'm so-and-so nurse. I'm in room so-and-so. Patient is such and such, and they are currently in respiratory depression and their heart rate is 41. Situation. You got 2 sentences to give that to me and you better make it good. Don't tell me about Sally who sells seashells down the seashore about 10 years ago. I don't that's got nothing to do with nothing. Does that make sense? All right. B, background. The background is this gal is her deal is she has cancer. and she has been doing chemo treatments. She has non-small cell lung cancer. All right. So she is on chemo and she's got lung cancer and it's non-small cell, which is the nasty stuff. So if she's got respiratory depression and she's got a heart rate of 46 and her O2 sats, 88, I know that she might have a collapsed lung. Why? Because the chemo is killing those cells. Plus, I already have a condition where it eats away at that area. So it's easy for those alveoli to collapse. Yeah. This is what I did when I looked at her. I noticed that her respiration rate was 25. I noticed that she had skeletal retractions. We were using intercostal muscles to get as much breath as we can. She's cyanotic. Okay, that's brass tacks. Her O2 sat is blank, 88%. All right, recommendation. This isn't, I think you need to do this, right? Because this is the part where they get really nasty, and I get it, but they don't understand where you're coming from either, because people don't talk anymore. Anyways, we're fixing that. Recommendation is talking to a kid. When you talk to a kid, you want to make them feel autonomous, but you also don't want to make them control the room. So you hand them two things and you say, do you want this or this? So we do that with docs. We say very simply, hi, can I go ahead and get them started on oxygen and maybe get an ABG because they're acting a little funny and a little confused? Or would you rather I do this instead? Do you have anything else further? And then of course you read back. Understood? Easy peasy lemon squeezy. Make sure that you understand the differences between those and how you would use those. I think pretty good. So let's move on and talk about people and their culture. What is something about a person's culture that we need to keep into consideration?
Every person is unique.
We are all unique. We are all connected. Very good. Are two people from the same religion of the same belief pattern?
No, you
No.
treat them as individuals. When you don't know, you put yourself in their position. You get them to start telling you about themselves.
That's it. Yeah. The best way that you can get a rapport with a patient is just to ask them about themselves. People don't ask people about themselves enough. And when they do, they're so out of practice that it just comes out really nasty. So make sure that when you ask a question, you are mentally prepared to tell yourself, if somebody asked me that question that type of way, how would I react to it? Try to. Are you going to fail at first? Yeah. Are you going to fail a lot? Yeah, I do it all the time. But again, it's about connection and explaining things to each other and telling them the why. So that's perfect. So no two people are ever alike. They don't think alike. It is going to play a role in our perception of things. So my culture or in your culture is going to teach us about things like pain perception. So how would that have anything to do with pain perception?
Because of their beliefs, they may interpret pain differently as well as treat it differently.
Absolutely. Yeah, they absolutely will. Tell me about how that has a psychological change in their actual brain perception of pain. Like we talked about how it does, from the outside, but what about from an internal structure? How does that change the brain pattern?
They can almost convince themselves of a pain level, right? So it's not okay to hurt. So my pain tolerance is going to be high because I've been taught that pain is not okay.
Yeah, okay, good. So environmental factors are going to change any type of physiological patterns in your brain. So if I, very simply put, was told, hey, get over your pain, it's not that big of a deal, my perception of pain is going to be like, oh, I just got a bruise, whoopity-doo, right? So keep that in mind that not everyone is going to think that. So that's why we get things like family history. Family history helps us kind of figure out if they are going to be a little more anxious than the average person. If I've got an aunt or an uncle or a mom that has ovarian cancer, well, that would be stupid because there's an uncle. If I have them that have, I don't know, skin cancer, okay? Would I be really concerned that I might have skin cancer? You bet your tail. Is that going to make me nervous every time I get a spot on my arm? Yes, because people age and get spots on their arm. Okay, well, that's going to cause a lifetime of anxiety. You betcha. Okay, good. I think we got that hammered in really well. Mhm. If somebody has no symptoms and you know that that pain should be present, how do we probe to see if they are in pain? So if I'm looking at a person, they're not grimacing, they're not doing anything, kind of like this patient that we were talking about earlier that was on a pain pump and was very young and had sickle cell. What could be a question that I would ask them very simply to say, okay, verbally, they have verbalized no pain.
Can you rephrase the question?
I like that. That's very Jeopardy of you. I dug that. Okay, cool. Let me think. If I am asymptomatic, like I'm looking at this patient and I know this patient's got a history of so and so and such, and I know that this person does not have a zero pain because they physically can't. Like if I got someone's bone sticking out of their leg and they're chill as a pill, and I have not given them any pain medicine, and they're being cool and they're smiling, they're like, no, I'm fine, everything's good. What's a simple question to ask them to make sure that they're truly not in pain? I know this sounds really simple, and it's so simple that you're asking me to rephrase the question, but it really is that simple.
Are you in pain? Just ask.
Hi, thank you. Are you in pain? Like I can't help but to notice your bone's sticking out of your leg. Are you sure you're not in pain? Right? Usually when you say something like that, that kind of a statement is going to ensue some type of reaction. Either it's going to be a dramatic, no, I'm not. Okay, good. It's definitely 0. Got it. Or nope, perfect. And that's going to be sarcasm, and that's going to indicate we do have pain and I need to probe further. Does that make sense? You always need to be watching people because they tell you an entirely different story. I always tell people, I don't care what you say. What you say, like you can tell me to the moon and back, all of the things you want to say. Until you show me action, intentions through actions, you truly never know, do you? Or you feel gaslit because you see one thing but are told another. So just be mindful of that. That's part of having wisdom, and that's everything. All right. So we talked about all of that. And we talked about that. Okay, good. We're moving along really great. We are, I feel halfway done. I know that sounds like a lot, but I go over a lot because who knows what's going to happen tomorrow, right? I still haven't even written the test. Oh, by the way, I only give you a 3-hour block to download and re-upload your stuff. So make sure that when we get in there tomorrow, and I give you that access code, that you understand you have to have it uploaded before you are done with the class period. And that's because of retrieval issues that have nothing to do with you. It's just it makes it more efficient for us.
Does it automatically upload? Or do we have to do something?
You have to download your exam, and I write it tonight, but I'm not going to post it to you guys until about 15 minutes prior to the exam. And then when I post it, I'm going to have this really long dramatic access code. And then you guys are going to take it and download your exam so that you could take it. You take it, and then you have to upload it back to me. So you just hit a button.
Okay.
Yeah, it's not a big deal. It actually does it automatically. Sometimes I have to make you like walk towards the door because for whatever reason, once you get to the door, it does like go through. And sometimes it'll give you a retry indicator. So you'll just know to walk to the door, and I'll take you over there and it'll be fine. It really is going to be okay, guys.
That's going to be an ExamSoft, right?
And the same platform that we use for our practice exam that everyone got through fine. All right, good. What is the number one problem related to nurses' injury?
Needle sticks?
You mean like our lower back issues?
Oh my gosh. Yes. All right. So what are things that we need to do to make sure that we maintain our backs?
Good body mechanics.
Back
Body
brace.
mechanics, use Hoyer lifts,
strength.
use other devices, and wear back brace.
Yikes. Yes, all of those things. And probably more in between. So the main thing is making sure that you are ergonomically set to be efficient, right? So that you do not hurt yourself. Squat with the legs, those type of deals. Don't try to be a hero unless you know you can handle it, but then don't do it anyways because it's not smart because you're going to get hurt. Okay. Don't ever just eat a bunch of pain meds and keep going. That's a terrible thing because you're masking your brain and telling it to not respond appropriately. So then when you don't take it, it goes crazy. Don't let that happen. All right, there's that. Primary prevention. Tell me what that is. Give me an example of it.
Exercise, healthy
Exercising.
diet before any disease process
Immunization.
starts.
I heard all the big threes, right? I heard exercise, good lifestyle,
Vaccination.
eating properly. I heard taking medication, taking supplements, right? To boost your immunity, right? I heard immunization. I think I've already said that before. So good. Sorry, give me just a second. Also in that, let's also think about things like prenatal support, folic acid support. Does that make sense? Right. So we do this proactively before we try to get pregnant. Why would we do that? Why would I start taking prenatals and start taking folic acid prior to getting pregnant?
To get your body
Boost your
ready.
immune system
I mean, yeah,
prior to the pregnancy.
there's also an element of a Pavlovian element, and a lot of you guys probably aren't familiar with this, but Pavlov, he was a very intelligent person who studied dogs. And what he did is he found that if you ring a bell, he could train them that when a bell is rung, it makes the person salivate because they're anticipating dog food. And he did this over a period of time. So what we found is sometimes when you stick a pill in your mouth, even if it's like a fake placebo pill where it doesn't have that medication in it, the action of you thinking that you are resolving an issue will fix the issue. Oh no, but there wasn't medication, right? There's this idea of transmutational neuroscience that I've been talking about, right? That I'm pretty excited about. So that's one example of that. Again, we're changing the energy, frequency, and vibrational pattern of our thought process of our brain. Therefore, we're literally flipping the battery on our perception. So perfect. Okay, now let's do secondary. What's secondary prevention?
Taking an aspirin with the history of heart attack.
Taking an aspirin with a history of heart attack. That was one of that we used in the lab. What else?
Mammogram screening, yearly screening of mammogram.
Yep. Okay. Those
Lung
are
cancer screening if you're a smoker.
good. Good. Now let's back up the train. What is secondary prevention? How is it different from primary versus tertiary? Like what makes secondary truly a secondary position?
You do that before symptoms start. Or even the
It can be reversed.
problems start.
I heard somebody, Missy Elliott, flip it down and reverse it. Perfect. So here's the concept. I am a borderline diabetic because I am pregnant. I finally got pregnant. Baby's going good. I'm getting a little bit heavier because I like to eat cake because I'm pregnant. That's what you do. You just get huge. No, you really don't. You should probably watch your weight because it's best for baby. So in the midst of all of that, I become a borderline diabetic. My fasting sugar is a bit higher, but not hateful. This is the part where the OBGYN looks at me and goes, look, you need to modify your diet. You need to modify this. You need to modify that. Or else you are going to become a full-on diabetic with this pregnancy. And you are going to have gestational diabetes, which is going to affect this baby. And it does, and it affects it in a very terrible way. A lot of times. So at that point, secondary prevention means when I have baby, I'm not going to be a diabetic anymore, right? And I don't have to be a diabetic if I just modify my diet. So it's this room of a little box that just kind of shifts like this, depending on how well you do. Does that make sense? So changing your lifestyle to fix your pre-diabetes, that would be an example of this. Does that make sense?
Yes.
Have lung cancer, you need to quit smoking. So let's go ahead and turn down that smoking. No, I don't want to. I want to smoke more. Okay, that's not going to go well. That kind of a deal. And then tertiary prevention. Tell me what that looks like.
You have the disease process that can't be reversed and you're at maintenance.
Good. What is a common example of this?
Maybe high blood pressure.
Going to rehabilitation after massive heart attack.
So going to rehabilitation after a massive heart attack is a good example because it's tertiary, but well, it's actually cardiac rehab is mostly secondary. And let me explain. Stroke rehab is going to be tertiary. So here's the deal. I've had a heart attack. A heart attack puts me back at a baseline after the heart attack is effectively healed, right? And when I say healed, we've done a stent, we've done some kind of interventional method, right? So we're in a secondary mark because we have effectively stented the problem. So I'm back at baseline, right? So it becomes secondary because if I don't take my aspirin, if I don't do cardiac rehab, which talks about exercise and diet management and education and all of those things, then I will have another heart attack. Okay. And it might be the big one that really makes things a big problem. Whereas in tertiary, I have had a stroke, and that stroke was a massive stroke. Okay. That's not a stroke that I can come back from. So that is considered tertiary because I'm going to do stroke rehab like therapy, physical therapy, because I've lost my ability to move at baseline. I'm already over that lap. Does that make sense?
Yes.
Pretty good. I was like, can I get an amen from somebody? I just want to make sure I had that clarified. So that is a good point, and I'm glad that we did talk about it because it is a little bit tricky with that. If you need clarifiers later on, just text me in the morning, text me tonight, whatever. Tell me about blood pressure and how that is related to fluid volume in the body. Specifically, if I have dehydration, lower pressure, higher pressure.
Lower.
Low pressure.
Sure, I got nothing pushing through. I got no fluid in my body. So
Vasoconstriction.
yeah, I have a fluid restriction in my body. Therefore, I don't have anything that's truly filling that supply that I have to have that nice, beautiful free flow. Okay, good. You guys are making me run out of stuff, and that's kind of perfect. Tell me a core, like one of the main assessments that we are going to look into versus a focused assessment. What's the difference between a main or core assessment versus a focused assessment?
A focused assessment is problem-based, specific area.
Mhm.
And then like a core assessment might be your regular, like intake comprehensive, like first time at the doctor's office, maybe.
Okay. So a focused assessment is I'm coming into the hospital and I am coming in because I have an abnormal foot pain. I'm going to focus my assessment on that foot because I have a change. So that is a focused assessment. So I'm going to check the skin. I'm going to talk about the color. I'm going to talk about any breakage or bruising, if anything's coming out of it, like any pustules, anything like that, right? Versus your basic assessment, which is going to be your all-inclusive assessment. Does that make sense? So like a comprehensive assessment is I do everything head to toe. In that are our core assessments. So our neuro, our cardiac, our lungs, our respiratory. Let's see, our GI. Remember our acronym that we talked about in lab on Wednesday, for those of you that were there for Wednesday. For those of you who are here tomorrow for lab, we're going to do the same thing. Don't worry about it. We're going to talk about it. Those would be your core assessments, your abdominal assessments core. Versus a focus, which is I'm coming into the room and there's a change. They're exacerbated, or like, I can see that they're cyanotic. That's a focus assessment. I'm focusing on just those lungs and just that windpipe and that source, and to make sure that we have oxygenation. Does that make sense? A little bit different. They sound the same, so it's kind of hard to pop them apart and together. So when we do a facial assessment and we're assessing for cranial nerve 7, can somebody tell me what cranial nerve 7 is?
Facial.
Very good. What am I looking for? Tell me how to do, what's the assessment?
Expression.
Assessment. And then what am I looking for? You got this.
Expression.
I know you got this. Expression.
Oh,
change it.
and like the taste.
Oh, that's a good point. Okay, so I'm looking at the face and I'm looking for facial symmetry. So if I have a patient that has normal facial symmetry and
Drooping.
then what is that an indicator of?
Stroke.
Yeah, absolutely. Perfect. You guys are just, you're gonna do great. Things are gonna go great. This is really
Is
good.
that also a palsy, like Bell's palsy and stuff?
Yes, that is absolutely correct. But remember, with Bell's palsy, a lot of times it is reversible. And when it is reversible, we're back at a baseline status. So if I see from symmetry to asymmetry, I know something's definitely not right. So good. What would happen to the nose? How can the nose be asymmetrical and it be a stroke and an indicator of?
Yes.
We do a lot of movement with our nose when we speak. So when we tell them to say words like a mountain, watch my nose, you ready? Mountain versus zoo versus outside. Do you see how much my nose moves? Like it's like a bunny rabbit nose. It goes, right? Like the little bunny moves. So what happens is if we have a flattened nose blade, that means one side of our nose will move, but the other side won't. It's the wickedest thing ever. So those little things make a very small change, and that is an indicator that we need to look at things. If I see that that's happened, what's the next thing I'm doing? Give me a vital sign that I'm looking at. If I notice that they have facial asymmetry, what's the next thing I'm doing?
Blood pressure.
Blood pressure and glucose.
Da, 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 da. Yes, perfect. Blood pressure. Cool. Tell me about how am I going to say this? Let me think this out. Tell me the 5 components of an assessment on a body system. We do this, we do this, we do this, we do this, we do this.
Range of motion.
No, I'm already messing up. Okay. When we listen, it's called what? When we listen to the heart, what's it called?
Oh, auscultation.
Auscultation.
Now go. What's the order that we do it in?
Skin, inspection of the skin,
Inspection. What's next?
external eyes,
Oh. Just inspection. What's the next? Inspection.
inspection of external eyes.
perfusion. Oh, something like that.
You're going so far deeper than you need to go. This is shallow into the kiddie pool. Okay.
Oh,
Inspection.
palpation.
There we go. Keep going. Yeah.
Auscultation. Percussion, I think, I believe.
Percussion.
Percussion. What does percussion sound like? What is
Yeah.
percussion?
The tapping
Tapping.
of the sinus.
We're drumming, right? So it's timpani. So percussion is an action that we used to do for ancient medicine that we still use today. And I can teach you how to do that in lab, which is really exciting. It's where we do a series of thumps and taps. Sometimes we tap it up here. Sometimes we do it down here. Every person's different because you have to just kind of feel it out for yourself. So we can actually hear when we go over an organ and if that organ is in excess of how big it needs to be internally. Oh yeah, it's super cool. Yeah. It's an old nursing trick, but it's actually ancient indigenous medicine, and it was actually used in Nepal a very, very long time ago. Very like towards the beginning of the presence of religious preferences type of a deal. So it's ancient, quite honestly, but very effective, and that's why it's passed down through the hands of time. What is auscultation? How do you auscultate lungs? What do you use? What side of your? I don't want to give names because then
The
I'm gonna
smaller side. I don't know the name.
The hard side left.
on your stethoscope. When you listen with a
Oh.
circle thingy that you put on the chest, do you listen to the big side or the small side? Diaphragm. You listen.
Big side.
Small side.
Small side is the bell, and that is best for hearing what?
Vowel sounds.
Vowel sounds on the bell? Murmurs, good. Murmurs, bruies, things of that nature are tiny. Also babies, little babies. The diaphragm is good for listening to vowel sounds. That's why I say diaphragm, because the diaphragm is kind of like in between those two pieces and parts, like the stomach. So to do abdominal sounds, to do heart sounds, any lung sounds, anything like that, you would use the diaphragm. If you're listening for a bruit, which would be a couple of things, it would be an indicator for something bad. It's usually here, or we would hear it in the abdomen itself, and we would use the bell for that because it's very sensitive, right? So what does it sound like to have a bruit? Can you explain what that sounds like, or a murmur? Because they're basically the same kind of sound, but not quite, but they kind of have the same characteristics. So what's a normal characteristic for a murmur?
A skip in the beat.
Okay. Technically there's a quiver in the beat, but it's the sound itself. It sounds very, very, very unique. Anybody know? All right, I'm going to make the sound of a murmur. You ready? I'm actually pretty good at impressions, so this is pretty close. It goes like this. Like that's almost dead on. So it's a whooshing, like swooshing sound. Do you hear the air go through it? Like I'm flying through the sky pretty fast, like it's exactly what it is. So that can only be heard on the bell. Really hard to hear it very well through any other form, though it's debatable. So percussion, we talked about that. We talked about auscultation. We talked about inspection, palpation. What order does it go in?
First inspection.
Okay.
Then palpation,
Okay.
auscultation, and then percussion.
And then percussion.
All right. Here's the point where I say, guys, give it a Google, because I have so much silence right now. I'm a little bit fearful, and this is something we're going to talk about for sure. So give it a Google, and then once you see it on the Google, because it's basically the same, the only exception is the abdomen. Once you do it, just go ahead and blurt it out, and then we'll talk about it very briefly. And we're making really good time. What we get?
Is it inspect, auscultate, percuss, and then palpate?
Okay. Is that the full way to do it? Just regular? What's the way to do it for abdominal?
It says palpate the abdominal when I just Googled it.
It said do what?
Palpate.
Palpate the abdomen when we're having abdominal pain?
I just Googled it. That's all.
You're fine. You're fine. So here's what I'm gonna do. I'm gonna put a circle around this because we need to talk this out. We need to talk about it. And very quickly, it's gonna take me another 10 minutes to explain that to where you guys understand the order it needs to go into. I would prefer to spend that time as we're walking in and getting prepared to get our stuff started, just because it's fresh and it's very important that we do discuss that, the order in which we take and why we do it differently for abdomen. Does that make sense?
So on Google, just really fast, I'm curious. It says inspection, palpitation, percussion, osculation.
Auscultation. Mhm. So the
Sorry, I said it wrong.
No, it's fine. It's fine. That's why I'm correcting you, because a lot of people will be ugly and say something sarcastic, and I'm just not going to do that. What I'd rather do is it's just a change in language. It's new for you. So yeah, there's a different way that you do it with the abdomen versus everything else, and there's a reason for it, because we're going to potentiate causing unnecessary symptoms, right? Basically. The idea of this is so difficult for people sometimes because there is an order you have to do it in, and it's not an order of That doesn't make any sense because why would you not auscultate first because it's less invasive? No, when I say less invasive, I mean to the surface of your body. When I'm auscultating, I'm listening to the internal system of your heart. That is the most farthest inside. If I slice this way and this way, it dips right into here. Hi, that's the central point. That's what we mean. Does that help? When we try to get the order of layers, a lot of people don't understand inspection. I can look with my eyes. It's the farthest plane away from me, right? And then what's next again? Palpation. I'm just touching the surface for heat, for temperature changes, to feel if there's skin cracking, skin breaking, skin sloughing, right? Then we got percussion, and we're literally thump, 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 because that's what percussion is. It's drumming, right? And then we go to the most central point. Does that make sense? If
Yes.
we need to clarify that. This literally happens every semester. I'm trying to find the best way to explain this possible. And I think that that's the best way to explain it possible. I hope that helped. We'll recap it tomorrow because I don't want to miss that piece. When we are documenting things about somebody, what types of things do we need to document related to a change in a patient?
What was the question again?
If you walk into a patient's room and they have a change, so like they're deoxygenated, and we have to go back and we have to document that because the patient's better now, what are some things that we would have to document?
What we
Accurately,
saw.
Accurately, yeah, we have to document accurately for sure. Good.
collectively,
Good. So some actual things we have to document. I, as the nurse, approached the room, saw that the patient was gone. She was sitting down, having trouble breathing. I assessed the patient. I took vital signs. I notified a doc. I got pharmacy involved. I got oxygen involved. Okay. What we're doing is we're explaining what we did to take charge. We're not explaining again. See, what happened was, does that make sense? Because the more that we speak and the more words we use, the more we give ourselves a big old gray window open up for us in a lot of bad ways. So we got to keep it short and simple and sweet and to the point. Does that make sense? Tell me the difference between what is the difference between screening versus a detailed or a comprehensive or a full exam?
screening is just checking the blood sugar or cholesterol check, like in a health fair.
So that is accurate. If they have diabetes and then they're checking their blood sugar, what is that called? Because that's something different.
Would that be maintenance?
Problem focused
It is maintenance, but it's called episodic.
or episodic, yeah.
It would be
Okay.
problem focused because if we were in a hospital setting, that would be problem focused. Do you see how it all kind of like turns in together? So a screening is a preventative method. I'm not expecting anything to pop up, but if it does, we know it ahead of schedule. Good. A detailed or focused or comprehensive exam. Here's the deal. They all call them the same thing. Detailed means comprehensive. By fashion, they carry the same definition or nearly. A focused assessment is just looking at this one acute situation, whereas a head to toe assessment is the entire body system. It is the idea of comprehensive, head to toe, complete assessment of the entire body system. Is that clear? We use so many big words and then we use slang on top of it and then we create more words, and that's why bootylicious is in the dictionary. I'm not even playing, look it up. It was the most ridiculous thing ever. So that's there as well as other things. And it's because we just keep making up more words and it just confuses nursing students and it makes me irritated. So I try to clarify.
Screening would be like a random check, like
Screening is
random.
doing a health fair. And in the health
Okay.
fair, I'm going to let people come in and I'm going to do their vital signs to let them know if there's any indicator that they might need to consider going to a doctor and, getting maybe a checkup. right? It's intended to not have anything of any grave detail pop up, but it does pop up very often.
So episodic and follow-up assessment is same, right?
No,
No?
not necessarily. An episodic could be I had a stroke and I'm going to the Coumadin clinic 3 times a week to get my blood levels thin enough to where I don't have another stroke, right? So that would be called an episodic event because I have to go make an appointment over there. I got to get my blood drawn, da 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 da, and it's specific to this one thing. Whereas a follow-up appointment doesn't necessarily have to be related to that. I could have a follow-up appointment because I am getting worse bruises and I'm also getting really dizzy and really tired. Does that make sense? So one is it's maintenance that I have to go there to get my blood done. So it's implied versus I am truly having an issue and I have to do something that's focused to that. Does that make sense?
Yeah.
Yeah,
Thank
you
you.
also mentioned post-discharged on episodic, and it's together actually in your video. So it's kind of confusing.
So it's confusing because post-discharge assessments would include a Coumadin clinic, which could then be perceived as both. Again, this is an idea of acute on chronic. You can have both. You can chronically have an issue that acutely pops up, aka Coumadin clinic would technically be both, but technically not be mutually exclusive. Does that make sense?
Yes.
Okay, good. It's the same way of saying, this is my brother, but we have different dads. Cool. Hopefully that like drove it home. It does get confusing. And the more questions you ask and the more you try to break it apart, just so you can have the right answer. With medicine, you'll find there's really a lot of gray area and there's good reason for that. Let's talk about subjective versus objective data. This one always kicks everybody in the tail, and we're going to talk a lot about it in all of the exams. All right. I'm going to go through every single exam because it's that big of a deal. Subjective data. Who does it come from?
What patient tells you?
The family or the patient.
Cool.
Coming from the
Objective data.
patient.
Where does that come from?
What you see,
Lab
what nurses
values,
Lab
are-
vital
values,
signs.
About
Assess.
facts. Okay. If I say I have a headache all of the time, do I have a headache all of the time? That is your
That's
perception.
subjective.
That is your perception. Is that the reality? Do you physically have a 24-hour a day, 7-day a week headache for the last 40 years of life? Probably not. You could, it's possible, but more than likely not. So that is why there is gray area because again, dimensional perception, which is a real thing. If you were on a lower dimensional perception, which doesn't mean you're dumb, it just means that you're not there yet. If you were on a lower dimensional perception, your perception might be a little more, and I don't want to even say exaggerated. It might be a little more skewed. It might be a little bit on this side of the spectrum versus this side of the spectrum, right? It's neither good or bad nor different because truly there is no good and bad. That's a whole nother discussion that really doesn't need to happen right now. So it's a matter of perception. Does it make it okay? No. Is it scary? Yeah. Should we put subjective data in if it comes from a notable physicist who is a subject matter expert?
Yes.
If it is coming from that patient and that patient is still a physicist who is the smartest person alive, I don't care if Nikola Tesla himself says that he has a headache in the forehead. Okay. I have to consider that objective data because I have to trust that that is his side of the story. But that is not the definitive side of the story, but an MRI result yielding a brain tumor versus what his complaint is makes a lot more sense, doesn't it? Because I have actual data to back it up. Please know objective versus subjective. Okay. I always say subjective means Sally. Sally is my patient, whatever patient you want to make that. I also say Sally is silly because subjective, I know what it means truly, but when I hear silly, then it reminds me of when patients go, I take my medicine all the time. I do. Or Dr. Google said, don't do that. And I'm like, okay, cool. All right. Versus objective, which means object. I hereby tell you that that is not okay. right? Because that is a guy going, nope, actually that's not right because this is what the collective data says. Does that make sense? As long as you got those two things, you're going to do really well. Very quickly, we talked about this. When you're dealing with varicose veins, when you're dealing with having venous insufficiency or having big legs that are have a lot of edema in them, what is the recommendation for these patients to take away their leg pain?
Compression socks.
Woo, you got it. What else?
Lasix.
Lasix. Girl, we don't know they got congestive heart failure. Why are you trying to lace somebody and kill their kidneys? That was exaggeration because it's not funny. Not quite there yet. But close, close.
Elevation.
Elevate it. Yeah, we're going to return everything back to the heart. Very good. Get all that fluid off. Perfect. So would we do that for arterial insufficiency? Will we tell them put on compression stockings for arterial issues?
No,
Yes.
No.
No. Why?
because it's
Because
gonna
the blood
constrict and they're gonna burst.
Yeah, yeah. So what happens is that on the inside of the body, what happens is when I put compression stockings on, it does this, kind of like a cast. And what happens if you put a cast on too tight, a blood pressure cuff on too tight, anything on too tight, what happens?
Stop the blood flow.
And what's an arterial deficiency problem mean?
Back of blood flow.
So you're literally stopping the blood flow with a problem with blood flow that doesn't circulate. So you're actually making it worse and you're causing more pain. Does that make sense? So the
Yes.
fat legs with venous insufficiency issues is based off of the reason you can get venous stasis ulcers is because the tissue is so wet on the inside, it's just tearing apart. Okay. So if you get rid of the wet, aka the fluid excess, aka the fat legs, the fat ankles that they always complain about at the end of the day, I can't get my shoes back on. That's their normal complaint. If I elevate the legs and I move the water out of the way, then the skin from the inside dries and then it starts to dry from the outside. Does that make sense?
Yes.
An ulcer that's a venous ulcer. Do I put compression stockings on?
I would say no.
You absolutely do. You absolutely remember, if I dry the leg, I heal the skin. So you'd put a very small barrier in between the two to, for rubbing purposes. But if it's taut on there with that compression like it's supposed to have, it's not going to really rub. But you want to make sure that you do that because you're going to dry out that leg because it's going to support the return of that fluid and redistribute it accordingly. Does that make sense?
Yes. So for venous insufficiency, you said no compression stockings, right?
Venous insufficiency, you want compression stockings. Arterial insufficiency, you do not want compression stockings. Venous stasis ulcer, you do want compression stockings on. Most people think an ulcer, if you put venous compression stockings on, it will then make the ulcer worse. Well, this isn't a pressure issue. The problem is you don't have enough pressure pulling everything back up like it's supposed to. So you want those on, right? It's a common miscommunication. Tell me about lung sounds. If I have a inspiratory and expiratory high-pitched whistling sound in lungs, what does that mean?
Asthmatic, maybe.
Ooh, what are those lung sounds called?
Wheezing.
Yes. Actually, that was more Strider sounding, my bad. All right, good. Tell me what bronchiovesicular sounds are. If you don't know, look it up. Bronchiovesicular. Try to spell it as best as you can. Let autocorrect pick it up when you see that it's right. This is a technique to teach you how to study, not to make you irritated. A definition is always going to be a definition. It's not going to have much of a variance of change. So looking up bronchiovesicular will give you a quick sentence to let you know what it is, and I'll fill in the blanks for you.
Well, Google says it is intermediate between bronchial and vesicular breathing. It has intermediate intensity and pitch with same duration of inspiratory and expiratory phase.
Is it normal?
It is, I don't know. No.
Is it
Yes,
not?
it's normal.
Yes, it is. And where is it located?
Between the first
bronchial.
and second intercostal spaces.
I mean, we can.
Scapulae.
There it goes. There it goes. It's right back here. Yeah. Right in between the shoulder blades. All the scapula is very good. Oops, something dropped. Okay. How about listening to the abdomen? If we're listening to bowel sounds, how long do we need to listen to the bowel sounds?
5 minutes.
Per quadrant? Or total?
3 minutes.
1 minute.
It could take up
Per
to,
quadrant.
listen, it can take up to 5 minutes for just one quadrant to make a sound. Okay, so you might have to listen to 2, 3, 4 minutes. If you do not have a sound after 5 minutes, are you going to listen to all the other quadrants?
Yes.
You're going to waste 15 more minutes on an ischemic bowel potentially? So here's the thing. If I don't have a quadrant sound and listen for 5 minutes, it is implied that that bowel is basically dead. So I've got to get them to emergency. Potentially, right? Maybe you don't have a sensitive ear and somebody else listened to it, and maybe it's 6 comes back. But it is implied if it's been 5 minutes, am I going to waste another 15 minutes on the ischemic valve that's already losing oxygen to that tissue and dying? No,
No.
I'm going to jump the gun as fast as I can. Okay. So the technical answer is 5 minutes per quadrant. But if you hear that one of them is dead and is not getting anything whatsoever, then it's implied that you got a problem. So you need to stop right there and just get on the phone. Does that make sense?
Okay, wait, what'd you say? Sorry. My kids are still awake.
It's okay. No problem. Throw it on mute. Here we go. Every single quadrant that you listen to, there's 4 quadrants on the abdomen. You need to listen for up to 5 minutes before you go hit the horn and ring the alarm. If you find that once you've listened to a quadrant and there is no sound after 5 minutes, then peristalsis, or the moving of the villi and the microvilli, moving the poop down the line, is not moving, which means it's potentially dead, which means that's going to have to get cut out, and in place of it, we're going to have to attach these 2 lines together, right? It's a big deal. The longer we wait, the faster that goes down the line and evolves and spreads, if you will, to death. So we need to get them to surgery as soon as possible, potentially. Okay. So I'm not going to wait another 15 minutes listening to the other 3 quadrants when I could be on the horn with a doc to assess it and see if we need to run them to emergency surgery. Does that make sense?
So question with that. You said like maybe I wouldn't hear it, but for example, maybe you would. So in that sense, when you don't hear the sound, right? Would you ask someone else prior to getting on the horn and calling the doctor, or you're gonna go right to calling?
So I was saying that to be nice, honestly,
Okay.
because if you can't hear, you might have a hearing problem, right? That might be a disability that you have. So that's what I meant by I might hear it different, or a doc might hear it different, because a doc is usually specialized in things like that. So we spend a lot more time learning about those sounds. And if our hearing and our stethoscopes are better, because we get better stethoscopes, then I'm going to be able to hear it better than you can. right? So that's why I said it that way. It wasn't meant to be
Okay, thank
doctor
you.
no superior. It's literally, we have better equipment, we have better technical stuff that goes with our contracts. I got one I got a stethoscope that I can hear you drop a pin about 100 yards away, and I could still hear it if I put it to the ground. It's really weird. That's a really nice cardiology stethoscope that I got from working a contract. So that's going to be different than your MDF $6.97. You know what I mean? So we need to have them in the room is what I'm trying to get at immediately, because they need to be making quick decisions because we got a big problem. That's done. That's done. That's already done. Oh, let's talk about the elderly people for a second. Elderly is a big deal. Talking about geriatric healthcare is a very big deal because, well, from personal opinion, we don't take care of our elderly well at all. And I don't understand that. And I'm not going to try to get too tangential, but how in the world do we let good people who have managed to live such a long time with all of that knowledge in their brain of survivability and not getting shot because they weren't a jerk, and managing to keep their composure so they didn't have a heart attack. We're going to treat that person with such grace and dignity. We're going to throw them into a convalescent home with a whole bunch of other people who also don't get taken care of because of staffing and 9,000 other issues. And that's just terrible. So how about we not do that as a species living in a free country, supposedly, where nothing is free and apparently. So what do we do to flip that battery of understanding and become a decent human being? What does that look like? What do I need to do? Do I need to consider things specific to elderly communities? What would I need to consider?
You would definitely need to consider like what is their, for lack of a better, their surroundings, or what kind of a community are they in?
Good.
What does that look
Or
like? And what
have
kind of
patience
care
when
are
they're
they
talking.
receiving in a long term?
Yeah, good. So are they getting the assistance that they need? So we're advocating for them. Good. Is the expectation that their body is going to be a little bit slower?
Yes.
Yes.
The age we get slower, supposedly. I haven't figured it out. Here's hoping it goes Benjamin Button in reverse style. But again, that's probably not going to be it. So as we age, our thought process, does it change?
Yes.
Yes, it does. Is it a sign of aging to lose your memory?
No.
Oh my gosh, no, it's not. What is the main symptom of acute confusion?
UTI.
Yeah, usually.
Very good. All right, so tell me about the elderly and peristalsis, the microvilli and villi moving the poop down the line in the intestinal tract. What does that look like?
It slows down.
Tell me about medications. How are they going to affect me?
They're going to stay in the
Like,
system
back you
longer.
up.
Oh my God, so much longer, right? Because things can't go down the line. Very good. Love it for you. 80% of your medications are absorbed in what organ?
Liver.
Liver.
All right, good. So the liver. And what does that mean that we need to keep an eye on specific to the elderly patients who have a lot of polypharmacy?
Hepatic function.
Liver function test.
Yes, thank you. Thank you. I think that's great. Okay, good. God, you guys are really getting this really well. This is exciting. You guys are really, man, you guys are a good cohort. That's exciting. That's really, wow. That's really, okay, I'm going to shut up. I'm tangential. How about their, when I'm asking them things, do they get a little bit more nervous than the average person if I ask them things very fast?
Yes.
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 So what do I need to do for them?
Slow
Give them
down.
time to
Give them time,
process.
slow down. Do I give them autonomy and choices?
Absolutely.
Yes, you give them choices.
Yeah. Okay. Do we how do I put this?
Take them to a private room.
Put them into a private room. Yep, because that's with any patient that they need to be talked to privately. Very good. We need to give them extra time. We need to be considerate of their skin. Why is it so important to be considerate of their skin?
Their
Fat
skin is
loss.
fragile and can tear.
What are those little pieces in their spine where skin splits really easy? What's it called?
Skin tag.
A skin tag is an overgrowth.
Skin tear.
Skin tear is something that's caused from an area called a bony prominence. So tell me a good bony prominence on an elderly patient.
Sacral. Heels.
Those
Yeah, for sure.
knees.
Yeah. Yeah, for sure. Perfect. I love that. Good. I got coccyx on the chat. Good. Do we ever tell anybody the following sentences? Man, do you normally carry a high pressure?
No.
Dude, what's it gonna do?
That's
It's gonna
assumption.
skyrocket their blood
What if I'm like,
pressure.
hey, I'm gonna count your respirations now. You just stay still. And I got hand size. What's that gonna do?
Make
They're
the
gonna stop breathing.
recommendations.
Hopefully, how's it going? It's nice to meet you. I'm so glad you guys are here. Very good. Perfect. I love that for you guys. All right. Tell me how we palpate skin. What are we palpating for skin? What are we looking for?
Nodules, texture of the skin.
Texture, size.
Nodules, texture of the skin. Yes. Good, good. Okay. Let's talk about the types of history. Tell me what is in a past health history.
Hypertension, diabetes, past medical history.
Heart attack.
Had a heart
Surgeries.
anxiety, right? Past health history. Perfect. Tell me what biographical data means.
Age,
Sex,
gender,
age,
Biological parents.
religion.
Religion, family history. Good. I like all of those answers. Reason for care. What is reason for care?
Their chief complaint.
Oh my God, who just threw out chief complaint? Megan Turner just threw out chief complaint. Yes, chief complaint is a old technical term. I'm not aging you, but it was the technical term I was given, chief complaint. What is the chief problem that you need to go ahead and come up to the chief with and bug the chief about, right? Which is the, well, it's not the head of the enlisted, but it's near. And that's amazing. Our commander in chief, right? So why are you messing with that? Reason for care. So that would be, I'm here because my bone's hanging out of my leg. Okay, that would definitely be a chief complaint. Tell me about, let's go back to the elderly. Tell me about their autoimmune responses.
It's slower.
The autoimmune responses.
They're prone to more infection.
Prone to more infection. What is an autoimmune response?
That's when the immune system kicks into like a bacteria
vaccination.
or
Okay, Google autoimmune response. So an autoimmune response is different from a vaccination, okay? An autoimmune disorder is when the body attacks itself, okay? So what happens is as you get older, your immunity goes down.
Oh, like arthritis and stuff.
But your autoimmunity gets triggered more often. So then you find yourself sick with the sniffles, which turns into pneumonia, which turns into does that make sense? Versus immune, which means I'm good. That would be a vaccination. Well, you're not truly immune with a vaccination, but it's pretty close. I just lied to myself again. Technically, I'm not going to get into it. It doesn't even matter. So I'm taking a vaccination. I'm having immunity, right? But autoimmune means it's coming back at me and attacking cells that it doesn't understand are my cells. Does that make sense? So like the rheumatoid arthritis, the lupuses, the sickle cells, all autoimmune issues. Got it? Versus immune, a little bit different. Does that make sense?
Yes.
Cool. That's a really good question to ask. Please don't think that I'm being funny, because I'm not. These are all really smart. That one's done. I'm gonna be done in about 5 more minutes, guys, honestly. Mm. Give me an example of an open-ended question.
Can you say that again?
Yes, and that is not an open-ended question. Can you give me an example of an open-ended question?
Can you explain that a little bit more?
Is your blood pressure always this high?
Yes, and that is
Simple yes or no questions, pretty much.
yes or no questions, or what type of questions?
Open-ended,
Closing.
the close-ended.
They are closed-ended. Let me explain this. If I say, are you feeling good today?
Yes.
What options am I going to get?
Yes or no?
Or no.
That means, am I closing the gap on what's wrong here?
No.
I am not closing the gap. So that closed-ended question is going to lead me to nothing. It's going to lead me to what I call fluff, shallow end of the pool, right? When we're dating people, when we get started off, we always ask the dumbest questions in the world, right? We ask, so where do you work? I don't care where you work. That shouldn't dictate anything about you whatsoever, or your profession for that matter. It's what's on the inside. Like, we're asking the wrong silly stuff. So to me, that is considered a closed-ended question, because all that's going to do is tell me how much you get paid, and I don't care about that, right? So we need to ask what's going to get down to the brass tacks, what's going to change the situation, right? Not what I can get out of you. So a better way to say that is, can you tell me a little bit about what you enjoy doing? Because that then gives me the depth of a person's soul, the range of their ability and their intellect and emotional intelligence. It tells me everything I need. And then it tells me what they truly enjoy, because when I say enjoy, you think of the kid, you don't think of the man in the machine. So that is an open-ended question, because I can go anywhere with that little buddy, right? Does that make sense?
Yes,
Okay, cool. Did I clarify that well?
you did, yes.
I almost just, I literally just stuck myself with a pen. I'm sorry. I'm tired. I'm ready to be done. We're down to 3 minutes. We're going to do this. We got this. All right. What is your first line of defense for any invaders that are foreign? Think organ.
Your
Think-
skin.
Thank you. Tell me about a stage 1 pressure ulcer.
Non-blanchable.
It's
It's red. It's the skin
blanchable,
is intact.
and it's closed still.
Stage 1. Good. Stage 2.
It's open. The skin tear is opened.
How deep?
It's usually on the surface level. It's just a skin tear.
3.
That's whenever it's down to, I believe, not the muscle, but the fat, pretty much, if I'm correct.
Layer name.
I'm sorry.
What is the name of the layer?
I don't remember.
Subcutaneous.
There we go. Yeah. I thought you were asking something else. I'm sorry.
Yeah, it's fine. What did you say?
She said subcutaneous.
Cool. That's the 3 is subcutaneous?
No, the 3 is, it's past the subcutaneous level.
Yeah.
So it's into the dermal level, the dermis level.
Okay.
Yeah.
4.
4 is down to the muscle or the bone.
Cool. And then what about eschar or necrosis? What are those?
It's black hardened
Black,
tissue.
hard, unstageable, pretty much.
Stage slough?
No, you cannot stage slough.
Okay,
No.
Cool. All right. Oh, if you have an elderly patient who is confused, what are concerns that you're gonna probably have on the radar, if I'm honest?
That they're
All risk.
all risk, and that they can hurt themselves, rip out things.
What can we do to help prevent those things from happening, to provide them with reassurance?
Metal arms.
More important than that.
Orient them to their surroundings.
Orientation. That's getting tricky, because you never want to tell them, "No, you're not here." What you want to tell them very simply is, "Hi, my name is blank. I'm a nurse." Okay, our body is encoded with information. beyond our understanding until you have understanding. But prior to that, you have knowledge in your brain that is genetically passed down to you, just FYI, right? And environmentally as well. So what we have found is that there is certain information we always know to hold to be true. Okay. So when you think of the military, what do you think of? Military, what are you thinking of?
Branches.
I heard protection.
War, protection, safety, net, maybe.
Structure.
That is the greatest word ever. Structure and protection and security. I like those things more. I'll let that one go. I get it. I can't get mad at that, but that's not originally what they were meant for. That's fine. I like the other answers as well. When you think of nurse, what do you think of?
Someone that's caring and that's gonna look out for you.
Protector, savior, right? I think that's fair, right? Miracle worker. I think that that's fair because sometimes we have to make a stretch and it just happens. Okay. All of those things good. So again, when we say the word nurse, that changes the transition of the brain and then gives a person what?
Hope.
I like
It-
that. Of
It
all
usually
the
helps
words,
them remain calm because they know that we're there to help them.
yes, absolutely. So if you quickly say, hi, my name is Molly. I'm a nurse. I'm here for you. I need for you to know that you're safe and it's going to be okay. If we've established that, that patient is so much less likely than to start anything. So whenever you get a patient that is truly confused, truly has dementia, and trust me, these guys get lost and found in the middle of Florida getting lotto tickets and they have no pants on. How did they get the freaking lotto tickets with no pants on? Did they have them on before? I don't know. I say these things to be funny, haha, but I had a patient who was an Ohio patient who, you ready for this? Got out of an assisted living facility, walked, got a ride all the way down to Florida and was found with no pants and a handful of lotto tickets. I cannot make these things up. Friends, it happened. Okay. So we have to give them, that's a lot of trauma that might be in there. They might remember it 1 second, might not. Who knows what the heck happened? They don't, but sometimes they kind of do. Comes in and out. So we have to keep those things into consideration because they need to hear very quickly, you're safe, you're secure, it's okay. We're trying to figure it out. And nurse is that word that you use. So I talked about open-ended, I talked about closed-ended. We talked about all the different parts. Guys, here, really quick, math. I'm going to give you a number, 0.12. I want you to round that to the nearest tenth.
0.1.
Thank you, 0.1. The first place after, okay, so I'm going to do it in your direction. If I do 0.12, that's right, 0.12, I'm going to look in the tens place. That would be the 1. What is the 2? What would be the 2 considered?
Hundredths.
Hundreds. And then beyond that, if I had a 0 here, what would that be?
Thousands.
Very good. All right, we're going to stop that. We'll do one more. What's the next one?
You got me.
Thousand.
100,000.
Ain't it 10?
It's 10,000s. Yeah. All right. And then 100,000s. Okay, good. So then let's just do up to thousands. So 0.12. So the tens place is the 1. 2 is sitting in the hundreds place. We only round if it's 5 or above. So what happens with that? We just make it 0.1. All right, let me do another one. 4.8.
0.5. Are we rounding?
We are rounding to the nearest whole number. Thank you for asking.
5.
5.
0.5.
The question 4.8.
We said
The
4.8.
number is 5.
4.8 is rounded to 5 as a whole number. Very good. All right, I'm going to do one that's really going to mess you up. Hang on just a second. All right, you ready? 0.456. 0.456.
What are we rounding to?
You are rounding to
You got juice in here already.
the nearest.
It
Guys,
is juice.
if you have your mute button activated or unactivated, activated. 0.456 round to the decimal number.
0.5.
It
Round to
would be
0.5 to the nearest.
0.
0.
So we're gonna round it to the nearest whole number, and we have all these numbers, right?
Oh, it's 0.
So here's what we do. That 6 at the very end, do we round that because it's over 5?
Wouldn't you round the 5 up instead of the 6?
Stop. You got to start all the way to the right. Okay. So 6 is going to round up, which is going to make that 5 also a round up, which is then going to turn that 4 to what?
5.
Because we rounded it. And
0.5.
0.5 is rounded what to the next whole number?
1.
1.
I told you I was going to make it tricky. You might, probably not. You could potentially see something of that nature. I just need for you to understand that concept. Okay. If I say round to the nearest whole number, that means we got to drag everything out until we get to the whole number. Does that make sense? Now, it might be like 0.811. We know that that's going to automatically go to a 1. But in this case where it's kind of fishy, you got to do it all the way through. Does that make sense? All right, that's my last contingency. Everything else is going to be simple rounding. We did all of those things. That's going to be your math portion, if you will. It's going to be okay. I know it seemed like a lot, but I told you, like, I covered a lot of material, and the material that we mentioned, I hope somebody watches this and is like, Molly's exams are so easy and she just gives them everything. Oh, I wish you would, because you would hear you guys answering advanced practice questions. Advanced practice meaning nurse practitioner questions, because we start off low and then we just kind of dance around it until we get all the way up to the top, and then we jump back down again. You guys should be very proud of yourselves. I'm going to tell you right now, and I should not say this because my other cohorts might listen to me who have already passed through this. You guys, if anyone is ready to come out of the gate running, buddy, y'all my football team. That's all I'm saying. And I don't even like football unless it's European, because that's the real football. We call it FIFA. All right, guys, any questions? If you don't, get off the line. It's 10 minutes till 11 o'clock at night. You should be ashamed. Go to bed. I'll see you in the morning. I'm proud of you.
Good night, everyone.
Good night.
Thank you.
Hey, guys.
I'm going to hang around for questions just in case.